this. Bear with me.
Yep.
Yep. Perfect. Okay. So this is the history. This is a 37-year-old lady. She's a gravid of 4, para 3, had 3 normal deliveries in 2013, 14 and 18. She's currently asthmatic on inhalers. She has a BMI of 25. She's had 2 episodes of reduced fetal movements in this pregnancy, just below 36 weeks gestation. She had 2 CTGs that were normal, and they referred her for an ultrasound, and was noted to have an estimated fetal weight on the 80th centile with an AC on the 95th centile. Baby weighed 277 grams roughly, 2977 grams. She was diagnosed GDM at 35 weeks as well and started on metformin BD. And then subsequently had 2 further episodes of reduced fetal movements, 37 weeks. CTGs were all normal as well, and she was noticed to be GBS positive. Unfortunately, I haven't got the antenatal CTGs, but she was an induction of labour 38 plus 1 for GDM. So just quickly to recap, what are we thinking the risk factors are here for this fetus? So GDM, we have to think every time we look at a fetal monitoring, if we think of the CTG, if we think we're assessing fresh eyes, we have to think of the whole clinical picture. We can't just look at one aspect of the CTG, because actually this will all take a massive impact. Okay, so this was the CTG on her admission to the antenatal ward. Okay, CTG started roughly about 2100 hours and was normal, classified as normal. So they did vaginal examination, roughly sort of 3/4 of the way into this CTG trace. Mum was reporting good fetal movements. Bishop score was 3, so they inserted Propes. That's the rest of the CTG there. Okay. I can't actually see, so if anyone sees anyone in the waiting room, do you mind just letting them in? Thank you. Okay. So Dawes-Redman met criteria at 49 minutes. The unfortunate thing about this CTG is actually we cannot see any of the contractions. So that's one of the downsides here. With the new CTG machines, Dawes-Redman especially, it's really important that the connection of the printer is really pushed in, so actually it's got good contact and it can print effectively. The CTG looks otherwise reassuring here. We know baseline sitting around about 150, 155 here as well, which is slightly higher than we're expecting, but we've got otherwise reassuring features. Okay, so we then go on to the next part of the CTG. Has anyone got any questions so far, or want to question the last CTG that we just looked at?
Nope. No.
So this is her subsequent CTG. She was about 6 o'clock in the morning, and she reported that she was having more contractions, more tightenings, and actually she was wanting some more pain relief. So the midwife popped her on the CTG and offered her pethidine. And about halfway through the CTG, pethidine was given. And we can see that she's contracting roughly 4 in 10. Okay. Anyone got any CTG?
Was there an examination prior to pethidine?
No, there wasn't. No. Which is what you probably want to expect, wouldn't you? Because actually, if we think to ourselves, this is a para 3 that we're augmenting. There's risk factors, obviously, that she'll go into precipitate labour. And she's contracting quite regularly here. So pethidine was given. Otherwise, reassuring CTG here. I think, anyone got any questions regarding this CTG? No, we all in consensus this is a normal CTG? Yeah, okay, perfect. So we'll carry on. So this is the rest of the CTG. All right, so criteria meets. Unfortunately, we don't tend to use this criteria meeting after the woman started contracting or after we've given prostaglandins. Main reason is sometimes that can be a reason why it doesn't meet. This baby seems happy enough and she's contracting. So just for the future, when we are augmenting women, just to be aware that not to put the Dawes-Redman criteria on, and actually just to look at the CTG and visualize the CTG. All right. So we'll move on. She then.
Also, sorry, is there anything? Sorry, quick question. Is there anything significant to note where the baseline was like 155 the night before and now 130? This is more appropriate, but is there anything in that?
So more often than not, if we look back on the previous CTGs, Mum was reporting quite a lot of fetal movements, which is another indicator, which is what we like to see. Here, yes, she's had pethidine. Again, that can have some effect on the fetus as well. More often than not, it might be the contractions, also baby's not moving as much. So that could be an impact. At the moment, there's no other risk factors, which is reassuring. If there were, then we'd maybe question. But a drop in baseline sometimes can indicate precipitate labour, but no other risk factors. Has anyone else got anything to add?
I would say if it has dropped from, for example, 150 to 110, although it's still within the normal criteria, I wouldn't consider it normal criteria. I would consider it as bradycardia. So, but from 150 to 140 to 135 is not significant enough. I would say if you are dropping 30 beats per minute or so, this is when the significance starts to click in your mind.
Yeah, and we have to think to ourselves, if there's any changes, are we picking up maternal pulse maybe, or actually is there any sort of abnormal features to that drop in baseline as well? Does that make sense?
Yeah, that's good. I think it's just one of those things you see, even though it's normal, it's a significant change, or well, how significant does it need to be to warrant investigation? So thank you, that's clear.
Thank you. So moving on, so there's no more CTG in the antenatal period. So she carried on contracting regularly. CTG was stopped here. At about 11 o'clock in the day, she reports further pain. So midwife examines, she's 6 centimetres, which is good. She then goes over to labour ward here. So this is the first CTG that we can see in labour ward. Any change to our previous CTG that we might be concerned about, or any risk factors that we might want to identify?
I would say it's slightly sinusoidal, something to watch, not to act quickly, but like to keep an eye.
Yeah, so we want to think to ourselves, is there any PV bleeding maybe? Is there anything that's changed? Mum still reports that baby's moving well, which is reassuring to us. And actually this might be the fetus maybe sleeping after pethidine. It's all of those we need to impact on. So once she came to labour ward, they were a little bit concerned regarding this trace. So a decision was made for an ARM, just slightly at the end of this CTG. ARM was performed, clear liquor. She was then 8 centimetres, so she's progressing very quickly. So we know this multip's going to have a baby very soon. Okay. So just towards the end, actually, we can see there's reassuring signs here. The variability is starting to get back to normal. And this is probably just a sleep episode for the fetus. Okay, so we're contracting regularly as well. Maternal pulse seems normal. There's no signs of infection at present. Maternal blood monitoring was normal as well, with all within normal range. Okay, so CTG goes on here.
So it is a question that I always like to ask. If you go to the previous slide,
yep.
If I am, and it is a debate. I'm not saying that I know the right or the wrong, but if, for example, in the previous CTG, where 6 centimeter you are concerned or whatever, and you do ARM, I agree with it if there is no 5 to 6 contractions below there. I would be more inclined if to be more cautious in a para-3 to ARM and increase the contractions. I would have given terbutaline, for example, if I am concerned. I wasn't concerned by the CTG, but I'm saying if I am concerned, rather than ARMing, which I know people like to think I'm pushing the labor forward, but as my old boss liked to tell me, that the train is going at 30, 40 miles an hour, and you are concerned, so you break the waters, it will go at 100 miles an hour. So you might not be able to remedy the situation by the terbutaline.
Yeah. So if we are concerned about fetal stress, try not to stress the fetus more with an ARM. Yeah. Perfect. Okay. So the CTG continues here. Okay. Client obviously is now feeling that she wants to push every time she has a contraction. As we can see, similar to what Naguib just said, our contractions are increasing. They're now sort of 4 and 10, a lot more coordinate now as well. There is loss of contact here. So what might we be thinking of if we're continuing with the CTG trace?
Applying an FSC?
Yeah, so that's something. We know the waters have gone now, and actually applying an FSC would be beneficial. It also, applying an FSC as well, also gives us some reassuring features by tickling baby's head on examination. More often than not, helps to provide an acceleration, which is reassuring for us as well. And we know actually baby's coping quite well, even though we are seeing decelerations. Okay, decelerations we are seeing here have got variability in them, and they are finishing before the contraction finishes as well. So they do look wide and deep, but actually, if you look at the contractions, they're the same. The contractions are lasting a good minute and a half. Okay, so we'll go on to the next slide here. So she's involuntary pushing, no external signs at present. But then we notice actually the CTG starts becoming slightly abnormal, okay? So the first 10 minutes here, she's starting to push, and we have a little bit of loss of contact here and a slow to recover deceleration. The midwife obviously tells the woman to stop pushing, and she wants the registrar to come into the room to review. Our previous baseline before, as we could see, was roughly maybe about 120, 130. So here, actually, have we recovered at all to the baseline?
No.
No.
Okay, so the registrar comes in, and this is a para 3. Obviously, she's pushing. This baby's definitely going to come. What do we think about? Sorry?
And one of the worrying signs as well here, Sorcha, is if you see the baseline and you try to calculate the amount where the baby is above the baseline or at the baseline, and the amount when the baby is below the baseline, you will see that it is maybe more than 50%.
Yeah.
So
And is there no FSC on at this point?
No FSC on at the moment. Sorry, this one has an FSC. No. So can anyone think of the type of hypoxia we might be thinking of in this case?
Subacute?
Yeah, subacute. Okay, so that's where we spend more time decelerating than at the baseline. Okay, we also could maybe argue that it could be acute, just because I think mentioned earlier that actually a lot of the time we're not spending at the baseline. So that time when baby's recovering and getting reoxygenated in order to help with that gases exchange, baby's not. Okay, so it's really important actually, if we have a CTG like this, not to just get task orientated, which is very difficult sometimes when you are seeing vertex advances, thinking to ourselves, okay, what are we doing to expedite delivery? Okay, so the registrar came in and the decision was made from instrumental delivery, more so a lift out than anything. So cup was applied, and then 2 minutes later, live male infant was born. Okay, now we mentioned earlier about second stage, and we said obviously that this is the most stressful stage for baby. We more often than not, if we are having concerns with the fetus, we are thinking about core gases as well, because more often than not, this helps with the holistic picture of the care for the neonate. It's not just because I like to go around and have a look at core gases. I'm doing it because actually it's really important, because that care for that neonate is really, really important. This is a risk factor mum who's got GDM anyway. A baby that's using its resources in labour more often not can become hypoglycemic quite quickly after labour as well. So, rest of the CTG there. Oh, where have we gone? Rest of the CTG here. So the outcome, baby is born in good condition. Outgoes 9, 10 and 10. The core gases were arterial 7.18 with a base excess of -10, with a high lactate of 7.3, and a venous of 7.20 and a base excess of -12 as well. So from looking back at that CTG that we just looked at and sort of correlating the core gases, what do we think this baby is telling us?
That they would have struggled to go on for too much longer with that base excess.
Yeah, so if we think prior to this CTG, this CTG that we saw just then, if I were to say to you, guess the gases, more often than not, it's a good way to interpret your CTG because you're asking yourself, if my baby was born right now, how would my baby come out? How would my baby cope right now? Is this baby got enough reserves to carry on in labour? Now, we pushed this baby and we knew she's a para 3 and delivery was imminent. This would be a bit different if it was a para naught who is at 8-9 centimetres and we've got a few more hours. But we think to ourselves, okay, delivery is imminent, but I wouldn't want the CTG to continue much longer. So we say about the pH drop-in with a subacute hypoxia quite quickly, so 0.01 every 2 to 3 minutes. And we can see that actually here, if this was been a normal core gas here, towards the end of this CTG, actually, our core gas is notably abnormal. Okay, baby was absolutely fine, didn't need any admission to special care, did become slightly hypoglycemic on the postnatal ward. Lactate came down as well, but baby and mum are both well. Has anyone got any questions regarding that case?
Only one comment, Sorsha. If you go to the previous CTG, and I want to ask people, the one before.
Mm-hmm.
Anecdotally, you examine her, and she is 10 centimeter. Head is -1. It's not deliverable eminently. What would people do?
Terbutaline.
Absolutely. So the answer is not a Cat 1 section. The answer is terbutaline. It continues. You can take to theater, yes, for a spinal and re-examination. Sometimes spinal terbutaline, putting a catheter in, the head comes down and it is deliverable. Because we have had many occasions where we ended up by a Cat 1 for a para 5 or para 6, and I'm not advocating not to do. I'm advocating only to say that at this point of time, when she's fully, that we can do something that can remedy the situation for 15, 20, 30 minutes to allow us to reach full dilatation. So we need to look at the full picture and how the situation is, and whether it is clear liquor, meconium, chorioamnionitis, not, GDM, not, because she was GDM. Is baby bigger? When was the last time she delivered? Yes, she delivered 3 years ago. If the delivery was 15 years ago, is different because the uterus is acting again like a primip and so on. So as Sorsha said, we don't want to focus only about the CTG, but also about the whole clinical picture.
Exactly that. So it is, we're looking at one CTG here, but actually, depending on which case we would be reviewing, it is all about the whole clinical picture, and that's really important, especially with bladder care in labour as well, because sometimes that's just literally it. When was the last time they passed urine? Because as soon as you empty the bladder, more often not, the head will come down. Perfect. Thank you everyone for that one. I'm going to move on to the next case. I do have 3, but I think we'll probably just do 2 today because I didn't realise that first case would be so successful.
Yeah, 2 is good.
Okay, so bear with me. Everyone see this slide here?
Yep.
Yep.
Yeah.
Perfect. So this lady is 31 years old. She's an ex-smoker before pregnancy. She's a gravid of 3 para 1 and had a 1 miscarriage, and 7 years ago had 7 years ago had a miscarriage and 1 emergency C-section for failure to progress at 5 centimetres 11 months ago, so quite recently. Her current BMI is 50 at booking. She had an ultrasound which was normal. She declined seeing the consultant or midwife regarding VBAC discussion. Okay, so undecided what she wanted. She just wanted to see what would happen. So at 39 plus 3, she arrived in triage contracting 4 in 10 with a history of SHROM at 1 o'clock in the morning, so about 4 or 5 hours earlier. They examined her and commenced CTG. They brought her over to lay ward to start the CTG rather than triage because she was a VBAC. CTG was commenced here, as we can see. So decision due to the BMI, they popped on a FSC straight away, and we can see quite good contact here. Client was in quite a lot of pain and was requesting an epidural, but because obviously we had no recent bloods for her, decision was made to cannulate, take bloods, and wait for the anaesthetist to review the bloods before epidural was being sited. So she has a few risk factors, as we know. She is a VBAC. We also know that she has a high BMI as well, which can impact on our plan of care. The TOCO isn't picking up the contractions here, but more often than not, with the decelerations, we can usually see what is happening. So she doesn't seem to be contracting too regularly here. What do we think? She's 4 centimetres and in labour. What are we thinking of this CTG?
Overall, it's reassuring. The D cells have ordering.
Yeah, it's reassuring. Baseline seems appropriate for gestation. We've got reassuring features, stable baseline. So yeah, I would want to adjust the TOCO, maybe see how often she is contracting, palpate, see if we've got good resting tone. I would think, having the back of my mind as well, she was fated to progress at 5 centimetres previously, so it's having that in the back of your mind that actually potentially that could happen again. So because she's a VBAC, having the doctors to review quite early on. So we'll move on to the next CTG here. So, client continues, reports the pain is getting worse and she definitely wants an epidural. Now, look at the time as well. This is a big impact on the care that we provide as well. So it's 7:15. This midwife just had a night shift. She's coming close to where her shift is ending. The woman wants an epidural. Sometimes it can be a case of, depending what's happening, has the anaesthetist handed over already, or we're waiting for a day anaesthetist and night anaesthetist to start the epidural. So all these are factors in the care that we give. The CTG is otherwise quite reassuring. Yes, we have decelerations. They're quick to recover as well. We've got a stable baseline, good variability. So at the moment, we're happy with this baby, but we want to actually see what's happening with mum. Now we think to ourselves, actually, we understand she's got high BMI, so that might be another reason why we can't think we're picking up the contractions. So we carry on. This is the next part of the CTG. So at around 7:30, sort of towards the first half of that 10 minutes, the woman says she can't cope with the pain anymore. We're waiting for an epidural to come. The blood's come back and everything's normal. The midwife VEs the client as she reports she's now feeling pressure. She's 8 centimetres, presenting part at -1, no capital moulding, and the client was involuntary pushing when she started to examine her. So the anaesthetist then walks into the room and wants to site the epidural. So towards the end of this CTG, starts siting the epidural. Now, it's really important, actually, when we are monitoring the fetus during labour, that when we are using the transducers, to make sure we are picking up this baby. There's been past cases, and definitely cases I've heard in previous trusts as well, of having intrapartum stillbirths during an epidural siting, because actually we haven't picked up that fetal heart rate. So it's really important. This woman's obviously got an FSC on, which benefits us, but your priority is obviously monitoring that fetus and not helping the anaesthetist. So if you have any struggling with getting that fetal heart, it's not a case of just leaving it. It's a case of, okay, we need an extra pair of hands to help support the anaesthetist whilst I'm focusing on the fetal heart. Okay, so CTG remains reassuring. Has anyone got any questions about this CTG that they think they're worried about, or they escalate about, or they think, I'm not too sure? No? Okay. Sorry?
I was just going to say, I'd rather be able to see what the contractions were doing, but that's the only thing. Really.
Yeah. If we were in the room, I think a BMI of 50 at booking, we understand that actually that might be quite difficult in labour, but you would be palpating, and sometimes on the actual CTG you can write little C's, can't you? And actually you'd know from palpating, okay, they're lasting 1 minute, I've got 2 minutes resting, I've got a bit of time. And actually, more often than not, when you have shoulder and decelerations and you're unable to see what the TOCO is doing with the contractions, more often than not, you can sort of see where your contractions are with the decelerations. Obviously, you'd want to be palpating. Just actually the start of this CTG here, you see we have slight acceleration here, obviously we have a deceleration, but this is where the examination was going on as well, and that's reassuring because actually we've tickled baby's head, and baby's saying, yeah, I don't mind that, I'm okay at the moment, I can keep going. Okay, so there's no more stress. So we'll carry on to the next slide. Okay, so 7:55 here, they're still trying to start the epidural, but the client starts pushing, so the anaesthetist abandons the epidural. At 08:03, midwife examines and she is fully at +1. At 08:05, we notice that vertex is visible, and by 08:12, baby is born. Okay. Now, beautiful CTG here, as we can see, this baby has literally gone from 8 centimeters to fully, from -1 to +1 very quickly. So more often than not, that will be quite evident in the fetal heart rate as well. Again, what do we think about this CTG? We know baby's coming, we know delivery is imminent, but we also know this is a VBAC as well.
It looks like a subacute hypoxia in that last bit, where she's pushing and delivering quite quickly. Otherwise, I wouldn't be extremely concerned, bearing in mind the picture of that kind of rapid progression.
Sorry, Chloe, you broke up a little bit. What did you say there? Sorry.
Sorry, I just said that this second stage bit looks like a subacute hypoxia. But bearing in mind how quickly she's progressed, I wouldn't be overly worried because she is making progress and baby will be out very quickly. Otherwise, I wouldn't be concerned unless I'm missing something.
So yeah, if we ever think to ourselves, if we've got a subacute hypoxia, it's understanding that we probably have 20 minutes before the core gases are going to be quite abnormal and this baby's going to come out with needing some support. So here, as we can see, the decelerations and obviously where baby's coming, we can see actually this is going to be very, very quick. We're not maximum maybe 8-9 minutes. So these, if we did take all gases here, we'd understand actually they would be within normal range, and actually the care that we'd give to the neonate would be reassuring. There's no other risk factors, there's no meconium, there's no infections. Actually, we're reassured. If there was any other risk factors, we have to think quite carefully. So if there was an infection, if mum was septic, if we think there's meconium on board, these are all risk factors that will affect the fetus. But in this case, actually, everything was fine. So baby was born with Apgar's on 9, 10 and 10, born at 3,580 grams. There was no core gases taken because it was an SVD and there was no clinical indication. It varies from midwife to midwife. Again, if you feel like you had an abnormal CTG and you'd like to take core gases, be my guest. Obviously, I think it's definitely helpful for you when you're caring for the neonate. But baby was discharged home with mum the next day with no care issues. Okay. So anyone got any questions about that case? No? Okay. So that concludes our CTG for today. So thank you everyone for coming. I hope you've learned something. I hope you like the discussion as well that we've had. There'll be another session next Tuesday again at 7 p.m. because we all enjoy spending our evening. If anyone wants to participate or if anyone wants to give me any CTGs they want to go through or we want to discuss, please feel free to participate. Okay.
Thanks,
Thank you.
Usha.
Thank you very much.
Thank you,
Thank you, Sasha.
Bye.
Thank you. That was really good.
Bye.